So after super anesthesia, we're going to use a Woodson and just elevate the papilla and any other coronal soft tissue. This is a cracked tooth, so I'm not sure how well it's going to come out. And we just got some movement with our 77R dog leg, and boom, out it came. Pretty easy. The question is, how did we get to this point? So how did we get here? Well, let's take a look at how we diagnose this tooth is cracked. So this is a periapical radiograph, and you can see where the arrow is pointing to the lesion of endodontic origin. Now we're going to assume that this tooth is necrotic because of that lesion, but you never know. So we're going to do our clinical exam. This is our abbreviated version. So we're going to do a probing depth, and sure enough, on the mesial-palatal, we found this almost 10 millimeter probing depth. And then on the buccal, same thing, we found this crazy probing depth right about there. And ironically, he felt nothing, no pain, nothing. So the next part is we're going to do our sensitivity testing with our cold test. We test all the teeth in the arch. And then he feels nothing on the tooth number 17. Same thing here again. Just checking before we go ahead and extract this tooth. But just before we extract the tooth, we're going to make sure that our electronic pulp test indicates that the tooth is necrotic. So this is a tooth here. It's going up to 80. We're in fast forward as well, so that's why the numbers are going super fast. So there's a couple of PFM crowns on that segment. So we're going to use an explorer to get underneath the crown margin so he can touch and let go. And I just get the patient to let go, dink, and that's it. So let's talk about anesthesia technique. So to extract this tooth, it's fairly straightforward. We're going to do an maxillary infiltration, and at the same time, likely you'll get a PSA block. But for the palate, what I've tried over and over a number of different techniques, using cold or using ice. Honestly, the best technique I've found is just using a lot of pressure with the mirror handle. So I tell the patient you're going to feel a lot of pressure, and then as I slowly place the anesthetic needle underneath the point of where the pressure is in the mirror handle, and I'll place just a tiny little drop of anesthetic. And this is going to take, you're going to watch the entire procedure right now in slow speed, in regular speed. So I'm placing a little bit of drops, It's just like tiny drops. Because I don't know if you've had a palatal injection, but it is extremely painful. If you go fast, slow, it doesn't matter. So trying to do the best technique you can will make your patient so much happier. So you can see how slow I'm actually going. And what I found is that by doing a lot of endo, I always have to do a palatal injection. And what I'll do is for posterior maxillary teeth, I'm going to do a PSA, so posterior superior alveolar block, including an infiltration. And then what I'm going to do is I'm going to do a palatal infiltration as well. So I'm telling the patient, you're going to feel lots of pressure, that's normal. And I'm watching for the blanching. And luckily, I was able to capture this with my iPhone, because it's really tough to get these types of shots with any type of camera. So you can see how slow it's been going to capture the anesthesia of this area, because I want to make sure that this patient is going to feel nothing but just pressure. And then that's it. So you can see the area that's blanched, and we're pretty much ready to go. And when you're using a rubber dam clamp for restorative, I'd highly recommend doing any type of palatal injection. It will speed up your preparation, speed up your restorative material restorations by not having to stop and ask if they're feeling any pain. So now we're just going to do exactly what we showed in the beginning of the video. And then the next video, we're going to show what the crack looks like once I do the root canal.